Good afternoon, dear audience. End of the day, some genetics. I will talk about non-invasive prenatal testing for rare chromosome abnormalities. My name is Márton Kónya. I lead a screening lab and a diagnostic prenatal lab in Czeizel Institute. My supervisor is Aniko Gal. My SMS is Isabel. And my vision is increase the effectiveness of genetic tests. And we would like to have pregnant women and physicians to find a good decision. I have two ongoing studies. The first one is about the accuracy of rare chromosome abnormality screening. The background is, in 1997, Dennis Law published that maternal blood can contain Y chromosome DNA. From this point, we know the pregnant woman's blood contains fetal DNA. Experts started to work on it. How can we use it for screening? But we have had to wait 14 years. And the first NIPT started in 2011 for Down syndrome screening, and then developed very fast later for Edwards and Patau syndrome screening and XY chromosome abnormalities. From 2015, the genome-wide NIPTs available, where can we find all chromosomes and rare chromosome abnormalities. This is the first screening test that can screen the rare chromosome abnormalities. Here you can see trisomy 7 from my lab. The frequent chromosome abnormalities, PPV, positive predictive values, well known. So, but for the rare chromosome abnormalities, it's not. The knowledge is much lower. That's why we started to work with it. We would like to help with this decision because the invasive procedure can cause a miscarriage. So we help for the pregnant woman to make a decision. Our aim is the PPV for each chromosome abnormalities, and secondary outcome is the frequency of positive cases. And we work on pregnant women, and we just collected genome-wide non-invasive prenatal testing and diagnosis for rare chromosome abnormalities. We hypothesize the NIPT finds almost the same value of chromosome abnormalities than amniocentesis, but there are so many discordant results. Here is the systematic research, and of the selection we found 17 reliable full text. The first plots show the screen positive for rare autosomal trisomies. You can see the screen positivity is around 0.3%. The next two plots show the PPV for all the pooled, all rare autosomal trisomies. The left side, you can see the method where we only say it is true positive when it was genetically confirmed. And the right side, we added that cases where was miscarriage or positive ultrasound result, because we think those are also true positives. These are the structural chromosome abnormalities. Yeah, okay. And the positive predictive value was 6 and 12%. For structural chromosome abnormalities, the incidence is 0.16%, but the positive predictive value was much higher. It's around 50% with both methods. We collected these values for all chromosomes individually. The A plots show the frequency, and you can see the 1/3 is trisomy 7, and some chromosomes is never positive in an IPT. The second and third show the positive predictive value for each chromosome, because it's very important for a post-test consultation, and the D and E plots show the true positive relative frequencies, and you can see that very big differences between chromosomes. Our strengths, we collected more than 700,000 pregnancies, and it's very important for analyze the rare cases. And this is the first study that individually studied each chromosome. Some chromosomes are very rare. It's very hard to statistically interpret, and the heterogeneity was big. The conclusion is that genome-wide is increased the false test positive and false positive rate a bit, but can detect all chromosome abnormalities over the detection limit. This is in +1. Yesterday we got a minor revision. And the second one is only for the false positive cases, because it's false positive cases, a discordant cases. It's not a technical problem, it's a biological background. The most of these cases is placental mosaicism. The placental mosaicism means the placenta is affected with chromosome abnormalities, but the fetus is not. But the placental mosaicism can reduce the placental function. Here is the clinical question, and we only checked the false positive cases and outcome and frequency of adverse outcomes. My hypothesis was the affected placenta can cause a higher risk for these adverse outcomes. Here is the selection. 14 study was reliable. And now we got the first figures. I can show you some. We checked EUGR, and you can see the odds ratio is 6.4, and the statistical significant higher than the control group. The small for gestation age is under the 10%, that's the baby size. Here the risk was around 4 times higher. We checked preeclampsia. It's not significant, but we will work on it, one-out analysis and so on. But the tendency is absolutely nice, but the diamond is very wide. We will check also, like in the first study, these risks for each chromosomes where we can make a statistical analysis. That means if we have enough data, we check which chromosomes affect more the placenta dysfunction. It's very small, and that we have to visualize it later, but we just got a few days ago. Now, I would like to talk about the special cases. It's the complex cases where not only one chromosome is affected, more, sometimes 6, 7, 8, 9, 10 chromosomes is positive for NIPT. Here, we do the first analysis, and you can see the background of these is malignancy. More than 50%, it was an unknown maternal malignancy. Here is the case, it's our case. It's so many different chromosome abnormalities. And here, after birth, a few months later, the patient were diagnosed with Hodgkin lymphoma. Yeah, it means that NIPT can detect maternal malignancy accidentally. And it's a very interesting question and ethical question, how can we handle these cases? So here we are now. We bring some our results to some conference, CEO for Budapest and Berlin. So, and thank you for your attention. And pregnancy is the only time when you can do nothing at all and still be productive.
Can I grab? Thank you for your lecture this late hour of the day. I hope my question is not unfair, but how do you distinguish, talking about the second project, how do you distinguish between fetal growth restriction and SGA?
Intrauterine growth restriction and
SGA. Well, basically, clinically, I think it's very hard to make a distinction.
It's a limitation because some study only reported under 10%, but the definition is under 10% is more for gestational age, under third percentage is intrauterine growth restriction, as Isabel told us.
Well, because in pathology, there is clearly a distinction between SGA and fetal growth restriction. So the fetal growth restriction is a nutritional failure for whatever reason, whereas the SGA is the constitutionally small baby. Mm-hmm. So this is why I'm asking the question.
Yeah, it's, we used these, but it's somewhere is different. For example, we had a publication from Netherlands that they used for EUGR 2.3%. I don't know why.
Well, it's more or less an arbitrary approach, but it's a hard definition. But perhaps when you prepare your paper, you might need to address these issues.
Yeah. Yes. Thank you.
For example, placenta histopathology might be an important factor that you might need to include or just look at whether that is available for it?
There are some papers, but for example, we did NIPT because the first trimester biomarkers was very low. And that shows that it's a plus. And sometimes I did, and some papers did a confirmation from the placenta. I did also one time after that case was trisomy 4 and extreme EUG around 30th weeks. And I got a sample from the placenta and it was full of trisomy 4. That baby was healthy. So it's what happened.
So in case of SGA fetus, it is small fetus, but there's a tendency in growth. But in case of intrauterine growth restriction, the placenta has a decreasing tendency when you perform the follow-up. And the IUGR fetus is at high risk for stillbirth. So is there any recommendation how can you increase the oxygen supply or nutrition of the IUGR fetus? Is there any medication or recommendation?
There is no paper, but I just thinking about in the first trimester NIPT result, maybe we can try aspirin cure, low-dose aspirin cure. Mm-hmm. But the strict follow-up, strict pregnancy care is very important in these cases, I think. But I think it's, but no, at the moment it's no prevention.
Yes, of course, but if you can somehow improve the placental circulation, it may be progesterone or aspirin. And of course, it is generally accepted that you have to check the fetal well-being by to check the fetal circulation. first of all, to check the umbilical artery, the blood flow in the umbilical artery. But recently, there is a new insight on intrauterine growth restriction because they check the umbilical vein blood flow because the fetus get the nutrition and the oxygen through the umbilical vein. So it seems to be logic to check the volume of the blood flow. So they check the diameter of the umbilical vein and the flow, and they calculate. But this is a very new thing and not wide literature at this moment.
Yes,
Okay.
now when we do the amniocentesis, we offer, if the result is negative, is every 2 weeks ultrasound check and flow check and fetal size check. We offer these one on the report.
I just wondering that do you have any data that the rare chromosomal abnormalities you analyzed are connected with any kind of assisted reproductive techniques or not? So do IVF enhance the risk of these kind of abnormalities or not? Do you have any data?
No.
I don't know.
No.
Okay, thanks.
The problem is if you see the number of positive cases, it's very low numbers. I cannot do a subgroup analysis at the moment. Yes, it's a question of the future.
In your second project, you mentioned maternal cancers. Which one was the most frequent?
Yeah, the most frequent cancer was the breast cancer, and after liver cancer and hematological cancers, lymphomas. In our cases, it's Hodgkin lymphoma, but different cancers. Yes, it's.
Can you please tell me what do you mean by structural chromosomal abnormalities?
Okay. Trisomy is when from one chromosome the cells contains not one but 3 chromosomes. For example, Down syndrome is a 3 chromosome 21, or here you can see a trisomy 7. Right. But the structural chromosome abnormalities when just a small or bigger part of some chromosomes missing or duplicated.
So everything that doesn't include the
very
complete,
small.
just a part of the
Just a
chromosome
part
is
of,
affected.
yes. Okay. Here, for example, is this. We have these problems from a malignant cell, but duplication 2 P75.3P11 means the chromosomes 2 is short arms, these 2 breakpoints, and duplicated this part of the chromosomes. These are the structural chromosomes.
From whom does it came from the additional chromosome of 21? From the pregnant or from the biological father of the fetus?
The trisomy.
This is a trisomy.
Yeah,
yes.
the trisomy, the 100% trisomy can be from maternal or paternal origin. The mosaic seams is always de novo mutation. It's not from the parental side.
Well, the additional chromosome 21 is in 94% of the cases came from the pregnant.
Yes,
and
from the
maybe
mother.
6% from the biological father.
Yes.
Do you know some explanation why?
Because between the sperms there is a race.
Yes.
But
Yes.
the egg is only one.
And those sperms
And
which contains one
and
more
and the
chromosome
other
21
and other
higher
causes of
weight.
it, the basic risk, for example, 15 years old woman, the risk for Down syndrome is 1 in 2,000. And for the fathers, this risk is quite the same, but in the same level. But for women, the 40-year-old woman, the risk of Down syndrome is 1%. It is increasing dramatically.